Thanks very much. I want to first of all start off acknowledging Usha Chakravarthi, Jason Slactor and Stephen Michaels, who really did the hard work. I'm slightly stealing their show here because these are the guys that worked in the Reading Centre, and it's much of the Reading Centre analysis that I'm presenting today in this first session, which looks at the safety of the device. I have the following declarations. For those of you that aren't familiar with the technology, stereotactic radiotherapy uses a device that doesn't look totally unlike a slit lamp. It's a non-surgical procedure. The patient sits down here, their head rests in a chin rest, and a robotically controlled device fires in 3 beams of radiation. They have a 4mm treatment zone at the back here. The beams overlap to split out the dose, and they overlap at the macula. Very importantly, the eye is held in position with a suction-coupled contact lens, and that makes sure that the eye is in the right position. If the eye moves out of position, then it stops the treatment until the alignment is sorted out. The total dose of radiation is about 1/10 of the dose that you would see with a head CT. It's kind of in the proportion of a dental X-ray. So the Intrepid design has already reported, but the safety data I'm presenting today comes from the Intrepid design, so I just want to quickly step back and go over the trial design. This was a randomized, double-masked, sham-controlled clinical trial. A total of 230 patients were included. The patients were not treatment naive, and it's very important to have that in mind when you look at the results of Intrepid. These patients were already on anti-VEGF therapy, and they were on a minimum of 3 injections in the year prior to enrollment, plus also needing 1 when they enrolled. So these tend to be the heavier Lucentis users. The lesion size could be up to 6mm, although in hindsight maybe we could have chosen 4mm as the treatment zone, as the 90% ISA dose only extends for 4mm. The patients were randomized to either 75 patients went to 16 gray, another 75 to 24 gray, and there was 80 patients in the control group. Now, all the patients had a Lucentis injection alongside their initial radiation treatment or sham. Thereafter, they came back monthly and had a monthly as-required dosing out to 12 months. The primary outcome was reported at month 12, and the study hit its primary endpoint, showing a significant reduction in the number of injections by about 1/3. The patients then went back to usual care, so we're not primarily reporting efficacy here. What we're looking at is for any delayed radiation change that may occur in response to radiotherapy. So this was usual care going right forward with a safety visit with some efficacy data at 24 and really only safety data at month 36. So looking at the 2-year results, there was a 25% reduction in the number of injections, highly significant, and the visual acuities, if you just eyeball that, there's no statistical difference, and there doesn't seem to be any noise coming up there in terms of a visual acuity difference, although in fairness in some of the subgroups there was a trend towards better vision in the radiotherapy group. If you look at the safety assessments, this was done by a reading centre who looked for, they looked at colour images through to month 36 and fluorescein angiography as well. They had a very systematic way of reviewing these. They were looking specifically for microvascular abnormalities that can occur in response to radiation. The graders looked at the images, they made a call whether or not they thought there were MVAs, which I'll call them going forward, so microvascular abnormalities. If they thought there was one, it went forward to a senior grader to confirm whether or not there was an MVA, and thereafter, if that was confirmed, it went to one of the very senior reading centre clinicians. In effect, it was mainly Usha, who made a call as to whether or not she thought this could be due to radiation. If it was thought likely, then it went to an independent masked assessment, so the reviewers had no idea whether it was pre-post treatment, which arm they were in, and they made an assessment as to whether or not they thought the radiation damage was real. Was there some microvascular abnormalities? If there was it due to radiation? And from that, if it was, could it have affected the vision? In terms of the things you look for with microvascular MVAs following radiation, these are the key features. Nerve fiber layer infarcts are cotton wool spots. Retinal hemorrhages, of course, excluding those that occur within the AMD lesion, because the AMD lesion can, of course, bleed. Telangiectasia is very helpful. This, personally, I think is probably the most useful side. Focal areas of capillary non-perfusion, vascular sheathing, and the OCT looking for intraretinal edema that was distinct from that associated with the AMD lesion itself. So if you look at the main result, 33 of 120 patients who were evaluated over the 3 years did have some microvascular abnormalities, so there were changes visible on angiography. Interestingly, of the 18 cases that we had moving from year 2 to year 3, half of those showed full or partial resolution. So these lesions seemed to pop up and then a fair proportion of them seemed to then resolve, so very different to the normal radiation retinopathy. The areas were small. Most of them were sort of in the region of 1 disc diameter or less, virtually all less than 2 disc areas in size. There were 5 cases where the MVAs were near to the fovea, so these are the ones that could have affected the vision, although in fairness most of the vision was affected by the disease itself. And if you look at the visual acuity outcomes, there was no significant difference comparing those who had MVAs with those who didn't. This is a slightly busy slide, but I just want to pull out the fact that most of these changes came, very, very few were picked up in the first year, and in fact none of them were confirmed by the independent experts, whereas most of them seem to be emerging in the second and third year with, as I say, about half of these 18 here showing resolution over the course of that year. This is very much a post-hoc exploratory analysis. Don't take this as an efficacy outcome, but we did have a look at acuity to see if there was any noise coming out of this, and effectively there was no difference comparing those with or without the MVAs, and similar to the control group. This is a map showing where the lesions occurred, and I find this quite interesting in many ways. First of all, they don't seem to be centered. This is the 90% ISA dose, and the dose of radiation falls off massively beyond that, so there'll be minimal dose out here. And in fact, more of the lesions occur outside the central treatment zone. There were a few that were thought to possibly affect the vision, mainly because they were located near the fovea. And the blue ones show those that have resolved over the course from 2 to 3 years' time. So most of the lesions seem to be outside the treatment zone, and there does seem to be a suggestion of a predilection for the inferior arcades, the inferior macula, rather than the top. Here's an example. This is a lesion that you see here, here with some capillary dropout and some subtle vascular changing. That obviously would not affect the vision because the patient has significant geographic atrophy. And it does suggest that maybe that's evolved, maybe that's got a little bit better over the course of 36 months. And that's a very typical lesion. Most of them looked, or a lot of them looked something like that. Here's one of the cases where it was thought that the MVA could have contributed to loss of vision. It was determined that, or thought that the AMD was the main issue. But what you can see here is, I don't know how easy or convincing that is, but there was thought to be some capillary dropout here. And because that was close to the fovea, it was thought that that might affect the vision. Another example here of one that did show regression. You see here again, this is something to look out for, these kind of telangiectatic, slightly staining vessels. Some capillary non-perfusion, and that seems to have changed there as well. So in conclusion, if you look closely enough, you can find microvascular abnormalities in a fair proportion of the patients, but they don't seem to affect vision, and they may evolve, they may get better. They are distinguishable from the normal AMD changes. Now, some of these features, in fact, we did another study where the reading center looked at AMD patients who hadn't had radiation, and 14% of them had MVAs. So it can be a feature of the AMD, and it's possible that some of these were the AMD itself, but I think there is genuinely something going on in terms of some changes in some patients. They may evolve. Most of them get missed. So, in fact, 95% of these were picked up by the reading center and weren't picked up on or noticed by the clinicians examining the patient. So they are extremely subtle unless you know to look for them. So thank you very much. Any questions? We can take questions as we go along for the minute.
Among the patients that you saw a regression of these MVAs, were these patients more actively treated with anti-VEGF? I mean, the question is, I guess, these patients are under anti-VEGF treatment, and perhaps this treatment also masks or is part of a therapy for radiation retinopathy.
Yeah, that's a very, very good point, actually. And the interaction between the radiation and the anti-VEGF is, I mean, I could be here for an hour answering that question. Interestingly enough, this came to us from oncology, where they use radiation therapy alongside anti-VEGF therapy, because, of course, Avastin came to us from oncology, where they were treating tumors trying to shut down the blood vessels. So there's thought to be a synergy between the two. Does it mask does it mask these changes? I suspect not. If it were a proliferative retinopathy, then for sure you would expect that. I'm not as convinced here. One of the issues with the trial was that actually the patients were massively undertreated when they went back to standard of care. The patients came from different areas in Europe. Some had more intensive treatment than others, and in fairness, it's very difficult to validate that treatment regimen. But generally speaking, if anything, they were undertreated.